Dr. Karamchandani, thank you so much for being with me today for Precision Medicine Awareness Month. We're going to talk a little bit about the evolution of pathology. I know you spoke at CRAN's biomarker conference on this topic, and we're hoping to extend the conversation.
Sabrina, thank you kindly for speaking with me, and it's always a pleasure to discuss this fascinating topic.
So did you have slides that you wanted to share? Did you want me to ask you questions or?
So my understanding was that we were going to have a conversation, and I'm happy to answer questions.
Okay.
I did discuss some of this in yesterday's presentation to CRAN, and I'm happy to go through that again. So we can go through that very quickly to set the stage, so to say. So let me pull that up.
Okay.
And we will start with that and open a conversation. So I'm not sure if you're aware, Sabrina, that the name of the practice of anatomic pathology has been formally changed in Canada.
No, I was not aware.
I see. Well, so this is kind of an exciting and interesting new development. For many years, the kind of medicine I practice in Canada was called anatomic pathology. In the last 7 or so years, an initiative was adopted to advance and modernize the name to reflect the current scope of practice. So, at the level of the Royal College, anatomic pathology is now diagnostic and molecular pathology. This is the first major name change of a medical specialty in Canadian history, and it does reflect a true change in the scope of practice, as what we do day to day has significantly evolved from the 1990s to where we are today. And that's reflected in this major name change. So I'm going to pull up some slides here. And I just want you to tell me when you can see these slides.
I can see them.
You can see some slides. Fantastic. So what we're discussing today is the evolution of the practice of pathology. And I mentioned this a little bit yesterday, so I'm repeating myself for those of you who may have seen yesterday's talk. But pathology really is historically what brought medicine into the modern age. From my perspective, the first pathologist was a French physician called René Théophile Laennec. And Dr. Laennec was actually the inventor of the stethoscope. He was a wood carver. His contribution to medicine was to perform auscultation and to listen to patients. And unfortunately, medicine being what it was several hundred years ago, many of those patients unfortunately succumbed to their pathology. And Dr. Laennec would actually attend the autopsy. And so he was the first physician to take a physical sign, auscultation, or the sounds that a lung makes, and then from that correlate it to some gross, which I mean macroscopic, something you can see with your eye, or microscopic change, and that would be true later in the practice of medicine. So whether we had the nomenclature at the time, he was a pathologist. And in the background, we have a story of the advancing history of microscopy. So Leeuwenhoek was a Dutchman who really advanced our ability to grind glass to specific shapes. That allowed for the creation of things like the telescope and the microscope. The first scientist who really leveraged this to produce scientific information was Dr. Hooke, who was the head of the Science Academy in London. We know about him from our high school physics. He's the inventor of Hooke's law for the springs. The same guy produced a book called Micrographia. And this was the first book that looked at the cellular composition of different materials and plants and described the concept that the world may be built of cells. The last guy who really changed the trajectory of pathology is Dr. Rudolf Virchow, a German pathologist, who was the first physician to advance a cellular basis of disease, including the world of cancer. So he had drawings of cells from young women with cervical cancer and showed that the cells in these cancers looked different than the normal healthy cells. And so he even described this evolution of a cell getting worse and worse and progressing towards cancer. That's in the 1870s, and that has held as a durable hypothesis for the last 150 years. So what I have in front of you here is a very practical example of classical pathology. I work at the Montreal Neurological Institute, where my neurosurgical colleagues are fantastic at performing advanced surgeries. So they would perform this involved operation to open someone's skin, bone, and cut out this dural-based tumor, and to do the best as they can to remove all of the tissue. A pathologist then looks at that at the macroscopic level, describes it. What's the size? What's the characteristics? Using that assessment, we choose what parts of the tissue we want to look at under the microscope. Now, that's a step that most people don't even know exists. But the reality is, if you have a large mass, there may be some areas that have more information than others. So that skip is absolutely essential, and it's performed by pathologists and pathologist assistants across the country. In the center panel here, we have classical histology. Now, most people, when they're trawling on the web and searching anything medical, may see pictures like this. This is the routine stain used by almost all pathologists around the world: hematoxylin and eosin. These stains extend back to the days of Virchow. Hematoxylin was derived from tree bark. It used to be aged in the sun, and it likes negatively charged things, so it turns nuclei that dark purple. Eosin, which was a textile dye, a lot of the dyes used in pathology were actually developed for textiles to make nice fancy shirts and dresses, likes to stain proteins. So when you look at the picture in the center, you'll see little dark purple dots. Those are the nuclei. Some pink stuff, that is the cytoplasm. And in this particular tumor, we actually see some calcifications. A pathologist will look at this picture, put it in the context of the patient's story, interpret those findings, and render a diagnosis. So this happens to be an example of a very common intracranial neoplasm called a meningioma. And we would look at all kinds of different features of that tumor to give a grade. The grade is useful to the treating clinicians to help identify prognosis. How is this going to behave for this patient? So using this example once again, we evaluate things like mitotic activity, the presence or absence of necrosis, which is uncontrolled cell death, and things like brain invasion. Those features help us determine the likelihood of local progression in the setting of this tumor, and ultimately help guide decisions around patient care. So an atypical meningioma, or grade 2 meningioma, has a higher likelihood of recurring locally. And so depending on the age of the patient, treating clinicians may choose to add radiation post-surgically in order to decrease the likelihood of recurrence. Now, I was very fortunate to start my career at St. Michael's Hospital at the University of Toronto in the Faculty of Laboratory Medicine and Pathobiology. And there I practiced both surgical pathology and neuropathology. As part of my practice, I had the privilege of reviewing hundreds of historic pathology reports. Most of my patients were being seen in the 2010s, so if they had surgeries long ago, these were from the 90s. So I saw hundreds of reports that looked like the one you see on the left. So this would be a pathology report for a mastectomy. And we see that the whole report is essentially 2 lines. You describe the organ, the site, the procedure, in this case mastectomy, and you provide a diagnosis or a pathology that affected the tissue. Now, a true mastectomy doesn't have any breast tissue margins. So in fact, it was a very progressive and forward-thinking pathologist who added that the margins were clear in the setting of a radical mastectomy. As you look on the right side of your screen, this is approximately 1/3 of the synoptic reports used across Canada to report on breast tumors. And what we see here, and I've highlighted some things in red, a lot more information is being used to decide clinical decisions from a pathology report today than was used in the early 90s. Here we provide distances to margins as an example in 6 dimensions: anterior, posterior, superior, inferior, medial, and lateral. And the distances of both the invasive component and a potentially in situ are recorded, and that information is all used to dictate choices around further surgery, radiotherapy, and the next clinical steps. More importantly, or not more importantly, just as importantly, many tumors, particularly breast cancer, lung cancer, and an increasing number of different sites, are accompanied by biomarker reporting. And so this would be an example of looking at estrogen receptor protein, progesterone receptor protein, and HER2 expression. In some centers, they perform another marker, Ki67, and all of these will help guide the therapy. So if a tumor is ER/PR positive, estrogen modulators may be used as a chemical agent to slow the growth of the tumor. If HER2 is strongly overexpressed, that was historically treated with a drug called trastuzumab, which is one of the earliest precision medicine therapies. And it was the first medicine that required a pathologist to provide an interpretation in order for the patient to receive the drug. So this happened in about the late 90s. So in the late 90s, from my perspective, the practice of pathology was fundamentally transformed by those words issued by the FDA. And so here we are years later, and the journey in the pathology lab no longer stops at a histologic diagnosis. Instead, we have to do an array of ancillary tests, and that includes immunohistochemistry, in situ hybridization, and different forms of genomic profiling. That can be a single gene test, it can be a panel gene test, it can be things like RNA sequencing, whole genome sequencing if required. And all of these different tests are combined to form the clinical plan for a given patient. And all this needs to be rendered in a timely manner. So in the world of neuropathology, for many brain tumors, we would like to start treatment within 3 weeks of the surgical intervention. So we have to collect all of this information and deliver it to the treating team within 3 weeks. And so yesterday I described a story of a young woman who had a cerebellar tumor, actually tumors, multiple tumors, who underwent surgical resection. And that surgical resection showed a tumor that was very aggressive looking to a pathologist. I'm not going to belabor this because this looks like just a sea of purple and pink, but this is a really aggressive tumor showing a lot of cells that are actively dividing. And on the far left and right of the screen, we have areas of necrosis, which is a word for uncontrolled cell death. Within 48 hours, we're able to do certain protein expression studies with immunohistochemistry that really help us solidify a diagnosis. But in this patient, given the multiple tumors and the atypical radiology, we were presented with a differential diagnosis. A differential diagnosis means 2 possibilities are still in the running, even with the amount of testing we've done. And in this case, that's a primary brain tumor called medulloblastoma. And given multiple lesions, the possibility of a metastatic process of a cancer with neuroendocrine differentiation had to be considered. What is not helpful to my clinical colleagues about this is that those 2 diagnoses are treated differently. So you give craniospinal radiation for one and you don't for another. And that's a big deal. And that matters to patients and it matters to the people that are delivering that care. We don't like to treat people unnecessarily by any means. So we have to keep working. In this case, that means in parallel, going back to radiology and working in the molecular world in parallel. So in this patient, first a chest, abdomen, pelvis CT was performed, showing no obvious masses. And that was followed by a PET scan, which was also negative. That suggests that maybe there's no primary tumor that's able to seed a metastasis, but there are rare cases of neuroendocrine tumors presenting as metastasis, I should add. In parallel, we've done a battery of molecular testing. And I think this is a really interesting new area in diagnostic molecular medicine because we're providing more information than we ever have before, and occasionally we're presented with information that we don't even know entirely what to do with it. So P53 is one of the most common mutations across many cancers. TERT is very common in brain tumors, but this tumor also had a KRAS mutation, and it's a specific, commonly recognized KRAS mutation, which has never been described in medulloblastoma. So if we had to stop there, you may say, well, I've never seen this alteration of medulloblastoma. Maybe it is a neuroendocrine carcinoma, even though the chest, abdomen, pelvis is negative, even though the PET is negative, because we've never seen this particular mutation in this setting. And I'm going to digress for a moment to tell you why I find it so exciting to practice pathology in 2024. First of all, we didn't have access to this kind of panel testing when I started my practice, even here in Montreal. That's been added in the last half decade. This mutation is currently not targetable with any approved medications, but there are several compounds being tested actively right now that seem to show efficacy at this specific mutation. So I find that really fascinating that as we collect this information today, that this may still even have new kinds of therapeutic utility moving forward. Coming back to this patient, we're still not there. We still don't have a firm diagnosis. We know this KRAS hasn't been reported in this tumor, but that doesn't exclude the possibility that it's a primary brain tumor. So we're very lucky that in Canada we have centers like Sick Kids Hospital in Toronto that can generate some very advanced diagnostic testing. And in this case, I'm talking about methylation classification. So an H&E and some scrolls from this case were sent to my incredible colleague, Dr. Cynthia Hawkins at the Sick Kids Hospital in Toronto. And this specimen was subjected to methylation classification. And as you see on the third line here, with very high confidence, this tumor clustered as a medulloblastoma, specifically sonic hedgehog activated, which is a molecular subtype, and described an array, a litany of chromosomal alterations in addition to helping us solidify a diagnosis. And I think this is a great success. We were able to confidently tell this patient what she had and guide the therapy appropriately. Now this took about 4 weeks because we don't have that testing locally, and even just shipping a sample can take several days. So that's one of the challenges with how we're able to deliver this high quality precision care across the country in an equitable manner. And so this is the evolution of pathology. We looked at the original idea of looking at a H&E under the microscope and rendering a diagnosis, and we still do that act. But to this histological classification, we add the relevant genetic and molecular information that's required to really understand how to treat the patient in a specific, individualized and precise manner. I also mentioned this briefly yesterday. One of our challenges is that we are generating a lot of information. This is an example of a real RNA sequencing that I sent off on a fairly recent case, and the pathology report is 6 pages long, and they're dense pages. And so the actionable information is in the box on the left. So we even need to learn and evolve how we communicate this information to our colleagues, because I don't think that it's reasonable to subject a busy oncologist to 7 pages of text to get them the information they're looking for. At the same time, we do want to provide them with all the information necessary to make their decisions. And none of this information is unnecessary or extraneous. So that's a tension that we're going to have to learn, confront, and be creative with. So we're in a very interesting age. Diagnostic pathology has evolved. We are now very heavily involved in genetically characterizing pathologies, and those can be cancers and non-cancerous pathologies. We need to understand some of the details and subclassifications in order to best guide the decision making. And it's a very exciting time because the practice of pathology has gotten significantly more complex. I've given you an example that even learning how to communicate this complexity to our clinical colleagues is a challenge. And another thing that I think about quite a bit is how do we communicate these results to patients? And in an age where patients are getting their own lab results, and I understand that's the case for Saskatchewan actively right now, I think we're going to have to think about finding tools to help patients digest and understand the meaning of this, and wherever we can, at least de-stress the anxiety of seeing information that they don't know what to do with. And I do think that running to Google can be a sometimes challenging next step. And I can assure you that my wife is one of these at-home Dr. Googles, and I've seen some unnecessary stress as a consequence. So I think that that provides an idea of the setting of the evolution in pathology. And I like the idea that all these challenges are opportunities. And I've seen my field evolve so much since I've decided to be a pathologist in the late 90s. And when I entered in this field, trastuzumab was just being approved by the FDA. I wasn't aware of that. And I had no idea that the fundamental practice of this specialty was about to change.
Dr. Karamchandani, that was so interesting. I really appreciated how you showed the reports, the pathology reports, and how they've changed. But I imagine now with the introduction of more precision medicine, precision oncology, that not just the reports have changed, but the requisitions that you're getting into the lab are changing as well. So I guess, with that change from the anatomical to the more diagnostic molecular, you're also getting requests to do all like the KRAS mutations or the BRAFs so that must have changed as well.
Absolutely. So again, I practice neuropathology specifically at this point in my career, and I take care of both adult and pediatric neuropathology. And one of the most interesting new areas is that we have some low-grade brain tumors that can be in very tricky places, like the cervical medullary junction. That's where your spinal cord meets your brainstem. And in the past, we've had to biopsy these tumors. Now, my neurosurgical colleagues are phenomenal people, okay? They are like astronauts living on the Earth with us, and they're able to do this safely somehow. It's like magic. And they always do cautious small biopsies. But there's a very real future where just by sampling the cerebrospinal fluid, that we're able to identify driver mutations, which in the setting of a low-grade tumor are targetable. And we may be able to proceed with precision medicine without a neurosurgical intervention. And we can even follow these patients longitudinally by looking at the mutation burden in a fluid like CSF. And in the future, even for other cancers like lung cancer, we're able to do that in blood.
Yeah. And so when I think about liquid biopsies, I always think about like a blood or in some cases urine, but I actually never thought of like the cerebral spinal fluid. So that's really interesting to see how liquid biopsies, the potential of liquid biopsies.
So that's another new challenge for pathology. I've talked about the practice of pathology getting more complex, but I'm going to use the example of lung biopsies. So the ability to do CT-guided lung biopsies has really improved our ability to characterize pulmonary lesions, because you can target even small blips that you might pick up on an imaging screening scan. We tend to get a core or two from the lesion, and sometimes you get a little bit of normal lung and only a little bit of tumor. Now, as we all know, the evolution in the treatment of lung cancer has evolved significantly in the last 10 to 15 years. And I see that even in my own practice as a neuropathologist, because when I received metastases as the first presentation, all of our tumors are evaluated with a next generation sequencing panel, as well as rapid immunohistochemistry for ALK translocation, ROS translocation, and PD-L1 expression to guide the selection of immune checkpoint inhibitor therapy. And so in the setting of the lung lesions, you have so few cells to work with that in what was once a goal of merely making a diagnosis of adenocarcinoma versus squamous carcinoma is now a game of selecting, if I'm only allowed to do 3 of the 5 necessary tests, which one should I prioritize? And I can assure you that my colleagues put a lot of thought into doing the best they can with every cell they get. But we have the tension of trying to take less and less tissue and trying to do more and more with it. And it's a struggle and tension that I think that both my clinical colleagues and my pathology colleagues have handled admirably.
Yeah, and I think the lung example is really interesting too, because when you're doing a lung tissue biopsy, it's also much more invasive than just a liquid biopsy.
Indeed. And some of the most effective stories about using liquid biopsies are in the world of lung cancer, specifically around the inactivating mutations, which render a precise therapy less useful. And so I think liquid biopsy is shown to be incredibly efficacious in that setting. And I have no doubt that that will grow in the coming years.
So I have just a couple of more questions I want to ask you. Um, the KRAS case study was really interesting, and the fact that it's never been described. And I'm wondering, is it because you were presented with a case and it could have been two different outcomes with two different regimens, and when you got to that, you did that molecular testing and you found the KRAS mutation. Do you think, like in other situations, people just didn't find that KRAS mutation because they didn't have to go that far? Or, we're really starting to get to a point where we're understanding, or I mean, I think we're not really at that point where we're understanding the potential of all the different genomic mutations, but like our concept of precision medicine is really starting to evolve.
Absolutely. So we're on the bleeding edge of innovations in this space, in very precise molecular diagnostic pathology. So the reality is, we've been diagnosing medulloblastoma for a century. We were not performing panel cancer testing on medulloblastomas. In fact, for a typical medulloblastoma, I would never order the test that uncovered that particular mutation. So as we have access to more tests, we are generating new kinds of data, certainly looking at tumors with new tests that had never been evaluated from that lens. So this is absolutely not the first so-called novel genetic alteration or combination of genetic alteration I've seen, that if you read the textbooks from as close as 10 years ago, described certain mutations as being mutually exclusive. And the more we do these panel tests, the more we realize that, oopsie, that we were wrong about those being exclusive, that 1% of the time, it's rare, but it happens that you can have two of these so-called mutually exclusive genetic events in the same patient. So the struggle is learning what to do with this.
Mm-hmm.
And I think that's an exciting opportunity. I think in the world of Mendelian genetics, the non-cancer diagnostic realm, there are places where you can go and very easily dump these new findings to help people, to help all people who are doing these kinds of genetic analyses evolve their concept of what a variant may mean, whether the term it's benign, uncertain, or malignant. We're doing a fairly decent job of advancing the general pooled information there. And if there is such a resource in the world of diagnostic pathology and cancers, I would love to hear about it, because this would be an example of a case that I think it would be beneficial to communicate to other pathologists. One of the ways we do that is by publishing cases and presenting them at meetings. And this would be an example of a case like this, which I've shared with you today. That is a way of communicating that information to my colleagues in pathology and neuropathology.
And so do you think that moving forward, you're going to do more of that testing in the tumors where you would have not normally done that molecular testing?
That's a really good question. And you've hit on a point about lab utilization. And that's a really interesting discussion all on its own, because I don't think that it's a good idea to do every test possible on every case. And I do think if we didn't have access to molecular methylation profiling in this patient, would we have relied on that KRAS mutation having never been described in medulloblastoma to shift our diagnostic label and undertreat that patient. So I think we have to proceed cautiously, intelligently, and I think my colleagues do a fantastic job of treating every case as if it were a relative. And so long as we keep that centered in our approach, I think we can start talking about when we should do which tests in which settings.
Yeah. Okay, and then last question, you talked about the need for tools to help patients digest this information. Do you have any recommendations?
Excellent. That's a really good question. And I know that there was a wonderful initiative based out of Toronto called MyPathology or mypathologyreport.ca. And that started to produce materials for patients to help them understand the implications of a diagnosis. My colleague, Dr. Fissé, is working on a related initiative. My colleague, Dr. Fissé, is based here at McGill. And my understanding is that's not ready for public launch, but I know that there's some more work being done in this area. And there are numerous patient advocacy groups that are also stepping into this arena. And I think CRAN is a beautiful example of that. All for CAN has some information to help guide patients as well. So this will work better if we do it together. And ultimately, I have found that in both research and in this aspect of clinical practice, proceeding hand in hand with patients is the best way to proceed, because our perception of what patients need to know is not always perfectly aligned with what patients want and need, and certainly how they need it communicated.
Yeah, that was really well said. On that note, thank you so much for your time today, and happy November, and thank you for participating in Precision Medicine Awareness Month.
It's my sincere pleasure. Thank you for your time.
Thank you for your time.